Presenter number 6 now, and that is Dr. Lauren Fortington from Federation University with the title Informing Decisions on Timing of Amputation.
Thank you. I'll just begin by making note that there's a couple of pictures on the second slide that people may find a bit confronting, so just a little warning. Every 30 seconds, a part of a lower limb is lost somewhere in the world as a complication of diabetes. In Australia, this limb loss is estimated to occur every 3 hours. Amputation for most people is the end result of a long-term complication of diabetes or peripheral vascular disease. Despite all of the advances that we've made in the prevention and treatment of these at-risk limbs, in some cases, amputation is the best or only option for ending pain, hospitalisation and infection, and ultimately enabling a person to live. There are two things we know. Post-operatively, within 30 days, 30% of patients will have died after their amputation. Second, mobility outcomes are better in those with greater preoperative function. These 2 points make me think, are we doing a disservice to some of our patients by these lengthy attempts to try and save the limb? My research challenges the idea that amputation is an end outcome or a failure of care. By viewing amputation as a treatment in a lengthy process, some patients can be better placed to regain mobility and ultimately have a better quality of life. So we take, for example, Albert. For 10 years, Albert's had diabetes type 2. 2 years ago, he injured his foot while working in the garden. He now has a severe diabetic foot ulcer that will not heal. He requires hospitalisation, IV antibiotics, and he's recently been told his only chance of a cure is an amputation below the knee. Even then, there's no guarantees. The surgery is risky, the wounds may not heal, and there is a significant chance that he'll die on the operating table. For Albert, the risk is even higher. He's 84 years old, and he's recently suffered an angiogram he's recently had a heart attack during a recent angiogram. Then there's rehab. At the very least, Albert will need 2 months of therapy in a nursing facility away from his wife and family. But what are his options? Without the surgery, the infection will probably kill him in a matter of months. Choosing life or limb is an important phrase by Fran Game that represents Albert's choice. While it seems confronting, and particularly to people who are not familiar with this area, but a positive early amputation, choosing life or limb, is not a new idea. We already use this in younger patients, patients who've had a trauma and face years of pain and lengthy rehabilitation and reconstructive surgery, choose to have an amputation so they can get out of hospital and get on with life. So why is it different in our older cohort? Part of the reason is we don't have the data to support our decisions in our process. People have more than one amputation. They may lose a toe and it might not clear the infection. So they might have further amputation at the partial foot level. Further up the limb, they may have both legs amputated. Currently, the way we collect, analyse and report data doesn't take into account these different levels, the timing of these different amputations, and the different limbs. In some data sets, we can't differentiate a left and a right limb. My research is looking at the methods of how we collect and analyse this type of data so that we can link this over time, so that we can take patients before they go into hospital and follow their journey through their different procedures. We're in a strong position to change this attitude of saving limbs at all costs. We do this in younger patients. We've seen it. We try and amputate a little bit higher so that we can fit different prosthetic components to a limb. Sometimes less is more. We now need the data that will support these right decisions in our older cohort. Thank you.